Hey guys, so next few weeks we're going to start talking about injuries and trauma, which is still a major public health issue in this country. We'll start off with bleeding and shock today. In the next few lessons we'll be talking about soft tissue injuries, head, neck, and spine trauma, abdominal trauma, and musculoskeletal trauma. But just go over a couple of statistics about trauma in the United States. And these statistics will not be on any exams. It's just kind of for your own knowledge. At least that might have said in the beginning, trauma is the leading cause of death for individuals up to the age of 45 years old. It's the #1 killer of young adults in the United States. You know that the overall #1 killer of adults is still heart disease. But trauma is still up there. It's actually the 4th leading cause of death overall for all ages in the United States, with the majority of deaths occurring from injuries, but the 2nd leading cause of deaths from trauma is from excessive blood loss and shock, and that's what we're going to try to talk about today. Almost 40,000 homicides and suicide deaths each year in the United States, so a lot of trauma deaths are due to very violent circumstances. There were over 3,000 suicides in the U.S. in 2001, and these are all CDC statistics. There were 43,443 deaths and 2.7 million injuries from motor vehicle crashes in the U.S. in 2005. And motor vehicle accidents and death and morbid injuries from motor vehicle accidents back in the 60s, what was really responsible for the development of EMS and emergency medicine as you know it today. So let's go and talk about bleeding and injuries from bleeding and hemorrhage and blood loss. The term hemorrhage really just describes a severe amount of blood loss to the point where it could be fatal if not addressed. But before we talk about that, let's recap and talk a little bit about the circulatory system and how blood is contained and how it's distributed through the body. And now the purpose of the circulatory system is to deliver oxygen and nutrients throughout the body and also transport waste materials as well. And there are 3 major components of the circulatory system. There's the blood vessels, and the heart. The heart, you know, is responsible for pumping blood throughout the body. It's a hollow muscular organ with 2 upper chambers, 2 lower chambers. The 2 upper chambers are called the atria. The 2 lower chambers are called the ventricles. The left side of the heart pumps oxygenated blood to the entire body. The right side of the heart pumps deoxygenated blood to the lungs. So if you start from a point of reference from the right ventricle, and when you talk about the right versus left in anything referring to anatomy, you're always referring to the individual's or the patient's right or left. So even though this chamber is left on your screen, it's considered the right atrium for the purpose of anatomy. So the right atrium receives deoxygenated blood from the body that's been stale and used up, pumps it into the right ventricle. From there, the right ventricle pumps blood up and to the lungs to receive oxygen through the alveoli and the capillaries in that area. The oxygenated blood then returns through what's called the pulmonary vein into the left atrium. So the left atrium is receiving oxygenated blood from the lungs, pumps it down to the left ventricle. The left ventricle is now going to pump all that brand new oxygenated blood out through this major artery called the aorta. And then that aorta is going to split off until it becomes smaller arteries and then ultimately capillaries to deliver oxygen to each and every cell of the body. And in turn, pick up carbon dioxide, water, and other waste materials from every cell of the body. So that's what the heart does. You have 3 major types of blood vessels. You have arteries, which carry blood away from the heart. Now, arteries are always under a lot of high pressure. They receive blood directly from the heart, so as the heart is pumping, blood flow is carried directly through that artery. Veins all carry blood to the heart, and in between you have the tiniest blood vessels called the capillaries. So with that, the last component of the circulatory system is the blood itself. And blood itself has four components. It has red blood cells, which are called erythrocytes, and those are responsible for actually carrying the oxygen molecules throughout the blood. Oxygen as a gas cannot really diffuse through the blood very easily, so you need some type of medium to carry them through. The platelets are responsible for clotting the blood to prevent damage, blood loss from minor injuries. White blood cells, otherwise known as leukocytes, are responsible for fighting off infection. And the majority of the blood is this liquidy material called plasma, which is mostly water, but it also is composed of some electrolytes and proteins as well. We'll talk about it another time. So when you're talking about bleeding, you can divide bleeding or hemorrhage into two components. There's bleeding you can see versus bleeding that you can't see. Bleeding that you can see is relatively easy to deal with if you can find it. Bleeding that you can't see requires a little more detective work. So we refer to bleeding that you can see as external bleeding. Three major types of external bleeding. So first you have bleeding that comes from an artery or an arterial bleed. Now arterial bleed, like it mentions before, is blood coming out from an artery. As we mentioned before, blood flow through arteries is very strong, very forceful, because it's coming directly from each contraction of the heart. So when you cut an artery, the type of bleeding you're going to see there is a very spurting type incident. You're going to get spurts of blood with each contraction of the heart. Because the blood cells, the red blood cells, are so oxygenated or so saturated in oxygen, the blood tends to have an appearance of very bright red color. So when you cut an artery, you get a very pulsatile flow of blood. And if that's not corrected very quickly, you can lose your whole blood supply in a matter of minutes, if not a minute. So these are the most life-threatening, most dangerous type of bleeding injuries that can occur. More commonly, though, you'll see a venous bleed, a break in a major vein. Venous bleeds, because they're not under as much pressure, because they're bringing blood back to the heart, tend to bleed steady, they flow. The blood is a little darker in color because it's usually not saturated with oxygen. But don't get me wrong, just because veins are under a lot less pressure than arteries, you can still die from a major venous bleed. Some of your major veins, like the superior and inferior vena cava, which brings blood back to the heart, your femoral veins, and any other major vein, if not addressed, can result in life-threatening situation. And then the most common type of bleeding you would probably run into in most circumstances are capillary bleeds. Remember, capillaries are very tiny microscopic blood vessels. Only one red blood cell at a time can fit through capillaries. So when you scrape your knee or you cut yourself shaving or got a paper cut, you've basically damaged mostly capillaries. Now, can a capillary bleed be life-threatening? Easy answer would be to say no, but there are actually circumstances where even capillary bleeding can be life-threatening. If a person has some type of disorder where their blood does not clot properly, or if they're on any type of blood-thinning medications, even some of the smallest wounds that we wouldn't think about can be disastrous if they're not controlled. So let's take a look at how the body actually facilitates blood clotting when there's a damage to the blood vessel wall. So what happens? We cut ourselves. The blood vessel gets ripped open. It could be a tiny rip, microscopic rip, or it could be a big injury. So the blood's flowing, The first step that occurs is the blood vessel senses that something's going on, and it's going to contract, something we call vasoconstriction. The blood vessels shrink. They shrink in diameter to try to slow blood flow down in that area. By slowing the blood flow down in that area, that allows for those platelets, those structures that facilitate clotting, to kind of slow down and accumulate in that area to try to form like a dam, a patchwork mechanism, so to speak. Now, the other steps in this process are a little beyond what we talk about here in the first aid class. So there are a lot of different other physiologic factors that come into play once platelets are activated. They send out chemical signals to a lot of other proteins that cause something called a coagulation cascade. The body always has checks and balances, so your blood is constantly making blood clots and breaking down blood clots and making blood clots and breaking down blood clots without even your body even knowing it. So there is a check and balance mechanism for that. But ultimately, all those coagulation factors are going to help enhance this platelet activity and cause a platelet plug to try to seal up that wound. Then that platelet plug is going to release chemicals to bring all those platelets together and ultimately form a blood clot. Now, blood clot can be small or blood clot can be big. Blood clotting can be appropriate, like when you cut yourself shaving, or it can be inappropriate when it occurs in a blood vessel leading to the heart, which can ultimately result in death. Sometimes blood clots can resolve themselves, and blood clots do break down over time, but it depends on the location of the blood clot itself that allows that to happen. So as we said before, there's 3 different types of bleeding. Let's go over that. Arterial bleed, which is pulsatile, bright red, very quick, very rapid, very heavy, and can be immediately life-threatening. Venous bleeding, which is slower, darker, more of a flowing type mechanism, which may or may not be life-threatening, depend on the location of the bleed. And then capillary bleeding, which is slow and kind of oozes. Most of the time it's not life-threatening, but as we mentioned in those other circumstances, once in a while it can be life-threatening if a person's on blood thinners or has some type of disease that inhibits their clotting mechanism. So how are we going to address external bleeding? Well, first you have to have some tools available to you. And most common tools to use out there would be your dressings and bandages. There are many varieties of dressings and bandages. For the most part, a dressing is some type of material that's sterile, usually made out of gauze, but sometimes can be made out of other materials as well. And this goes directly on the wound to stop the bleeding. Most of the times they're built to absorb a lot of blood. Some are even chemically treated to enhance clotting, but just the gauze itself will help some clotting to form. But overall, a dressing goes directly on the wound, and it should be in a sterile package. On top of that, you have bandages. Now, bandages are designed to hold the dressing in place. Bandages obviously should be clean, but they don't necessarily have to be sterile. Most often, they're made out of porous gauze material, but there are other types of bandages as well. A really handy tool to have out there are something called triangular bandages. The medical word is cravats. There's a lot of uses for these type of bandages. They can be used to hold dressings into place. They can be used to make makeshift slings. They can be used to actually hold splints on legs. There's a lot of different uses for them. They're very handy tools to have. So you have some type of external bleeding. Let's say a cut wrist or a cut scalp, for example. Well, let's hold off on the scalp for a second. Let's talk about bleeding on an extremity to start out with. What's the first thing we want to do? Well, there's a couple of steps. First of all, we want to apply direct pressure to that wound. Okay, direct pressure is going to slow down the blood flow. First of all, it's going to help stop the blood from coming out of the body, but it's also going to slow down blood flow, allowing for those platelets to get in control. Tourniquets are another tool we'll talk about in a minute, which, to give you an example of how guidelines change, if we were going to talk about tourniquets 10 years ago, we would have been telling you, no, tourniquets are absolute last resort. You really don't want to use them. You put a tourniquet on, the person's going to lose their limb. we've learned over time that actually not to be true. Tourniquets can be very life-saving, and they are recommended in cases of severe bleeding. An old, non-proven technique of addressing external bleeding is elevation, keeping the arm or keeping the leg above the level of the heart to slow down blood flow to help the bleeding stop. It's debatable whether that really works or not. Most of the new first aid textbooks say it's never been proven scientifically, so it's not recommended. I got to tell you, I deal with bleeding all the time. If I'm suturing a wound and there's bleeding and I keep it elevated up to a certain level, I find anecdotally it works. But that's just my opinion. We'll talk about splints and topical hemostatic agents at another time. So your first step is direct pressure. Direct pressure is the first method of controlling bleeding. You can apply pressure dressing after that, and I'll show you how to do that in a moment. Obviously, you don't want to put pressure on objects that are stuck in the body. You want to try to bandage around them. So, for example, let's take bleeding from a forearm. Okay, this is a pretty gross looking picture, but it's just makeup, so don't worry, it's not really real. So somebody's got a huge gash in the forearm, there's a lot of blood. First thing you want to do is apply direct pressure. Now, preferably, you want to have gloves on. You want to apply direct pressure with a sterile dressing, but you may not have a sterile dressing readily available, or this person may be bleeding very heavily, in which case it's appropriate to take your gloved hand and apply direct pressure over that wound right by itself until you can either get the other tools available to you, you can have somebody help you out and grab some dressings out of the first aid kit. If you don't have any gloves, if you don't have any first aid kit, if you don't have anything available to you, you obviously want to protect yourself from any bloodborne pathogens, but you can have the person who's bleeding, you can instruct them to apply direct pressure onto that site. Sometimes people will freak out and they don't know what to do. It seems pretty obvious, but if that blood's coming out of your forearm, you may not be thinking too clearly. So even the smallest thing, like telling them to put their hand over the wound and apply pressure, is good first aid. So obviously, like I said, you want to, at some point, put a sterile dressing over that wound and continue to apply direct pressure to that wound. You want to pack large gaping wounds with sterile gauze and apply direct pressure. So gauze dressings come in a variety of different sizes. Most commonly, you'll see square 4x4 dressings, but they can come in very big, huge, what we call multi-trauma dressings as well. Bleeding cannot really be done effectively unless that wound is exposed. So if you can either roll down the sleeve, roll up the pants, or if you have what's called trauma scissors in your first aid kit, you got to cut that piece of clothing article off and expose the wound for you to treat it adequately. So like I said, first thing we want to do is to control bleeding by direct pressure. Pressure, dressing. Next thing we can do is take one of our gauze bandages and apply what's called a pressure bandage. Now, if you haven't looked at the videos that are on your lesson plan for this week, I really encourage you to do so, because obviously being this is an online class, I can't show you how to do this in person. So it's very important that you look at the instructional videos so you get a better idea of how to handle this. So what a pressure dressing does, it wraps around the sterile pressure bandage, I should say, wraps around the sterile dressing, which is applied to the wound, and it's applied in such a way that it gives extra pressure to that site to help facilitate blood clotting. Just a little side note here, if you see what's going on here, anytime there's an injured extremity, hand, one of the first things you want to do, or maybe you want to do very quickly, is get any jewelry off of that extremity. This is an injured extremity, don't know what caused the extremity, but usually with injuries and trauma, swelling occurs. If the swelling starts working its way down to the hand and that finger starts swelling up with that ring on it, That ring is a constricting tourniquet. It's probably going to cut off all blood supply to that finger. They're going to lose that finger if they don't cut it off. So just a side note for you to keep in mind. Okay, so as I said before, tourniquets are used when direct pressure does not control bleeding. You might see tourniquets used on TV and movies where someone takes off their belt and wraps it around the leg, or takes a piece of cord or something. It's really, really recommended to not use makeshift tourniquets, to use pre-made, commercial, fabricated tourniquets, because improvised tourniquets may not work very well. It may give you a false sense of security, and may actually lead to more complications. So again, there are videos on your blackboard to show you the application of a tourniquet, but as we said before, when we used to say tourniquets were almost a last resort, you want to do all these different things first, the paradigm has changed. Have a very low threshold for making the decision to apply a tourniquet. If you're applying direct pressure, if you're applying a pressure dressing and it's still bleeding heavily, another thing I should mention though is when you apply a pressure dressing, when you apply a sterile dressing, I should say, first dressing you put on soaks through with blood. Do not remove it, even if it's saturated with blood. Continue to put additional dressings on. If you remove that blood-saturated dressing, you're ripping apart the blood clots that may have already formed, and you're going to start the bleeding process all over again. So, but like I said, first, second, maybe third sterile dressing, person's still bleeding very heavily, have a low threshold for taking out that tourniquet and applying it to the extremity. You really want to apply it as close to the wound as reasonably possible. A general guideline, and I'm only saying general, I won't hold you specifically to it, is you want to apply it about maybe 2 to 3 inches away from the wound. Obviously, you want to apply it closer to the body than further to the body. In medical terminology, we call that proximal. Anything further away, we call distal. You never want to apply a tourniquet over a joint. There is a chance that if that tourniquet is on for a long period of time, the person may lose that extremity. They may have to amputate it, life over limb. But as I said before, we've discovered over really much the last 20 years, with military conflict in the Mideast, that we really have about a good 6 hours from the application of a tourniquet to the point where they can get this person into the OR and surgically fix whatever the problem is. Once a tourniquet goes on, however, the tourniquet must stay on. It never comes off in the field. Once that tourniquet is applied, it's basically cutting off all circulation to that wound. So we're going to talk about this a little bit later. When circulation is cut off, oxygen is cut off. So then all the cells in the body start metabolizing without oxygen. And a lot of byproducts and a lot of acids and a lot of toxins are produced in that process. So if you wind up taking that tourniquet off, all those toxins and acids that are produced in this area get introduced into the entire body, and it can cause a person to go into cardiac arrest. So take home point, once the tourniquet goes on, it stays on. If you apply the tourniquet and apply it properly, and the person's still bleeding, it is indicated that if you have one available, apply a second tourniquet. The second tourniquet goes further away or closer to the body than the first tourniquet. So the first tourniquet goes on. If you decide a second tourniquet, it goes a little more proximal than the first. And a tourniquet works by wrapping a band entirely around the extremity and using this little stick that's called a windlass to twist it and tighten it and twist it and tighten it. And somehow you want to secure that band so it doesn't open up. As I said before, most commercially made tourniquets have a little mechanism in place to facilitate that. If you're using a homemade tourniquet, it may not work properly and it may cause those complications that I just talked about. So those are the issues with using a tourniquet. The tourniquets should be a part of any first aid kit. There's a whole public health, public safety program called Stop the Bleed that's occurred in the wake of all these mass shootings that have occurred over the last couple of years. And when things like this happen, the shooting in Florida, the shooting in Vegas, a lot of people's lives were saved by bystanders on the scene applying bleeding control techniques and tourniquets. There was very delayed EMS response available. So another example of why bystander first aid is so important. And as I said before, elevation is an option, but there's very little evidence to support it. It's not really going to hurt unless that extremity is broken in several places. But as I said, don't use elevation as the only means to control bleeding. First, direct pressure dressing, maybe elevate the extremity if it helps. But if you put on your pressure dressings and your pressure bandages and bleeding is still occurring, you may have to consider the use of a tourniquet. Something that's relatively new in the world of first aid and EMS are what's called hemostatic dressings, hemostatic agents. There's many different types. The bottom line is they're chemically treated to help promote clotting. So this is a brand name that you see here called Quick Clot. They can be used when direct pressure is ineffective or impractical. I'll talk about a couple of situations like that. In EMS, we use them for long transport times. Some of them are just regular gauze dressings that have chemical treatment on it. Some of them are packages of powder that you just pour directly into the wound. I think I have a couple of videos on that that you can watch. They're associated with some complications. Mostly if the person's awake and talking, they burn. They tend to hurt a lot. But again, life over limb. So when you're assessing external bleeding, you want to go through a step-by-step approach. First of all, check your own fear. If the sight of blood is too gory for you, think about what you can do. Think about how much you can do. Make sure that whatever causes the injury is not a danger to yourself. So if it's a violent situation, stay out of there until it's secured. If it's a dangerous situation, can you do anything to reduce the danger? Do you feel worth taking the risks? It's a decision that's made on an individual case-by-case approach. But in general, make sure the scene is safe. Sometimes you can see how bad somebody is just by looking at them. Now remember that whole ABC approach. Obviously, the person's talking to you, screaming, crying, they have an open airway, they're breathing, they got a pulse. If they appear unresponsive and you see a massive amount of blood, forget about the airway, forget about the breathing. You want to go directly to that bleeding. So if you see somebody with a spurting arterial bleed, you want to address that first. Stop the bleeding first. ABC in your assessment does not necessarily have to be done in that order, as long as they're all done at some point before anything else. So don't forget to use standard precautions, gloves, goggles, anything to protect you from getting exposed. A little story: when I was a medic in the Bronx years ago, and we got a call for a shooting. If anybody's familiar with the Bronx, the location was Crotona Avenue and 183rd Street. And as we approach the scene, we see police surrounding the area. There's a huge guy on the floor, writhing around, flailing. Looks like he was shot in the neck, probably a drug deal that gone wrong. And everywhere he was flailing, a stream of blood was flying around with him. So police are going hysterical. Bystanders are going hysterical. But the bottom line is, my partner and I weren't going anywhere near this person. So we got back of the ambulance. We got our personal protective equipment, our body substance isolation on, which included mask, goggles, gown, gloves. As important as it is to think of somebody else's life, you got to think about your own first. And there's no way we're going to bring any of this stuff home to our families. So that's always the first thing to consider. So remember, Control bleeding, your first step is with direct pressure. Apply sterile dressing. Apply a second sterile dressing. If the bleeding is saturating the sterile dressings, do not remove the sterile dressings. If it's a little bit of bleeding, apply a pressure bandage. If it's a lot of bleeding, forget about the pressure bandage for now. Get on with the tourniquet. Provide care for shock. We're going to talk about shock in a few minutes. And injured extremities, musculoskeletal injuries, we're going to talk about in a few weeks. So there are some issues with certain types of areas where bleeding is external. For example, if you suspect a skull injury, you're not really going to want to apply direct pressure to that area. Facial trauma, you've got to worry about compromise to the airway, especially if the person is bleeding in the mouth. Another term for digital trauma to the nose. Anybody who doesn't know what digital trauma to the nose is, it just means picking your nose, which is the #1 cause of nosebleeds, even though people will deny left and right. Sinusitis is a true infection, bacterial infection of the sinuses. When it's really complicated, people can sometimes blow their nose so hard, or sometimes mostly from picking, that the infection itself can cause a little bit of bleeding from the nostrils. Not the worst thing in the world. A lot of people associate nosebleeds with blood pressure that's out of control, hypertension. It's really a matter of what came first, the chicken or the egg. Did the blood pressure get so high that it caused blood vessels in the nose to burst? Or did the nosebleed start and now the person's freaking out and their blood pressure is out of control? Either way, it needs to be evaluated. First step is to stop the bleeding. We always talked about clotting disorders. For example, a condition called hemophilia, which is a genetic disease. That's a genetic disease which results in the inability to produce certain clotting factors that can make the platelets work. People with this can bleed to death very easily in a very short amount of time. Esophageal disease, somebody who's throwing up blood. Common in alcoholics, really bad alcoholics. They do damage to their esophagus, their stomach. It's a matter of really internal bleeding that we'll talk about in a couple of minutes. So what's the proper way to address a simple nosebleed? Well, contrary to what you might have been shown in school from the school nurse or from friends or family, you do not want to have the person lean their head back. By leaning the head back, blood is going to travel from the nasal passages to the back of the throat, cause them to gag, maybe even vomit, cause more pressure in the sinus area, and cause more bleeding. Instead, very simple thing to do is have the patient sit and lean forward. And simply pinch the nostrils together for a good 10 minutes. If after 10 minutes, wipe away all the external bleeding, take a look, give it a minute. If they're still bleeding, then you want to pinch the nostrils for another 10 minutes. Usually in most otherwise healthy people, that's enough to stop most nosebleeds. If it's a situation where it's not stopping, or if this is a person who's on blood thinning medication, you may need to bring them to the emergency room for emergency intervention. There's a number of different things we do in the emergency room for these, including packing the nostril with gauze, kind of burning the blood vessels together so they stop bleeding, a number of different things. Another situation I want to talk about is bleeding to the scalp. Now remember, we talked about the first step of external bleeding is to apply direct pressure. In most cases that's true. But look at this big cut to the scalp. Now you got to ask yourself, what caused that cut? Were they simply struck on the skin with a sharp object that just went right through the skin and caused that bleeding? Or was that wound caused by some blunt trauma to the head, like a baseball or a lead pipe, that could possibly lead to a skull fracture? If that skull is fractured underneath that scalp, last thing you want to do is apply direct pressure and push pieces of the skull into the brain. So in this case, you got to be a little crafty. you want to obviously stop the bleeding, but this may be a good situation for one of those hemostatic dressings if you have. If not, you just want to pack on lots and lots and lots of gauze to sop up the blood and gently try to secure it around the scalp. There's a couple of videos that shows you in your blackboard, but don't apply direct pressure if there's any chance there may be a skull fracture. Scalp wounds tend to bleed a lot because there's a lot of blood vessels in the scalp. So a little cut can bleed a long way. You may even notice sometimes that somebody took a shot to the head and they're bleeding and you don't even see a clear cut. The scalp is so vascular that sometimes a blunt shot to the head that doesn't even break the skin can cause blood to just kind of ooze through all the pores. I've seen that myself. That's kind of messy and hard to control, but it's not the worst thing in the world. So let's talk about a little bit of bleeding that you can't see, internal bleeding. Obviously, you can't see internal bleeding, so you have to think about, is this person at risk for internal bleeding? Did anything happen to cause internal bleeding? And what are the signs and symptoms of internal bleeding? Well, what are some things that can cause internal bleeding? Remember that your body has a lot of, for lack of a better word, hollow chambers. The chest cavity, the abdominal cavity, the cranial cavity, these are all semi-hollow structures that hold a lot of organs. So somebody can lose a lot of blood in the chest cavity where the heart and lungs are without showing any immediate signs or symptoms. A person can bleed almost their entire blood volume into their abdominal cavity before we even know it. So it's important to understand what can happen. Any type of heavy blunt trauma to the body, like motor vehicle accident, getting hit with a baseball, getting hit with a bat, a fall from a significant height, anything that can significantly disrupt the organs of the body can cause internal bleeding that won't be apparent from the outside. People who are more prone to internal bleeding, once again, people on blood thinning medications, people that have clotting disorders, elderly people tend to bleed a lot easier than younger people. So the signs and symptoms may not be readily obvious, so you have to have a high index of suspicion. Look at what we call the mechanism of injury. Look at what the patient's complaining of, and look at any obvious signs and symptoms as well. Common sources of internal bleeding are injured organs. Two very important organs to think about are the liver and the spleen, both in the abdominal cavity. The liver, at any point in time, carries about 25% of your circulating blood volume. Somebody's involved in a high-impact motor vehicle collision. Well, actually, 3 collisions occur. The first collision is when the car hits whatever the car hits, whether it be another car, a tree, a wall. Remember, a body in motion tends to stay in motion until acted upon by something. So the car is stopped by whatever it hits. The second collision is your body going from 65 miles an hour to 0 miles per hour. It could be your body's collision against the steering wheel and the airbag, hopefully. It could be your body's collision against the steering wheel, but the seatbelt and the airbag, hopefully. It could be against the steering wheel, not so good. It could be against the dashboard, not so good. Or it could be out onto the pavement if you're ejected from the vehicle. Very bad. That's your second collision. Remember, that body's going from 65 to 0. Well, all the organs of the body are going from 65 to 0. And that's your third collision. The brain smacking up against the skull. The heart smacking up against the sternum. The liver, the spleen smacking up against the rib cage. There's a ligament that holds the liver in place right down the middle. It's called the falciform ligament. You don't need to know that. But when that body goes through a sudden deceleration, that ligament can cut through the liver like a knife, and then all your bleeding occurs. So remember, have a high index of suspicion, even if they're not showing any outward signs or symptoms. The term hematoma basically refers to a contained collection of blood that can contain a significant amount of blood. If you've gotten a goose egg on the head from a baseball hitting you and it's swollen up, that's a hematoma. But hematomas can be apparent on the surface of the body, but they also can be internal and not so easy to spot. I mean, when it says use signs and symptoms to estimate severity of blood loss, that really doesn't apply to first aid. But in general, most people can tolerate a blood loss of about 500 milliliters or a pint. If anybody's ever donated blood, that's about what they draw for any blood delivery. Anything more than that, though, will manifest itself in some signs and symptoms. The more blood lost, the worse the symptoms are going to get. So speaking of signs and symptoms, you look at the mechanism of injury, you go through your ABCs, your airway. Let's say this person is awake talking. Okay, good. Airway's open. They're breathing, maybe breathing a little more rapidly. C, in circulation. That's where you might start seeing some signs. Maybe, maybe not. If they're losing a lot of blood, their skin may pale. It may be a little sweaty, maybe a little cool. If you know how to feel for a pulse, you may have a hard time finding one. We're going to talk about more about that in a few minutes. But then you may have some other subtle signs and symptoms when you do your secondary approach. Head-to-toe exams, some pain and tenderness to the chest, bruising on the chest, pain and tenderness to the belly. If they happen to feel like there's blood in their undergarments, they may have fractured their pelvis. If they're vomiting and you see what appears to be coffee grounds material, it could have perforated something in their stomach. Most of the time, it's due to a perforated ulcer. If they're vomiting bright red blood, that's usually a blood vessel breaking in the esophagus. As I said, very common in alcoholics. Coffee ground material is usually from a stomach ulcer that's kind of mixed blood and digested food and comes back up. If somebody's bleeding from the rectum, that could be a sign of some type of surgical emergency, like cancer. Could be a sign of bowel obstruction. Could be a sign, if it's bright red blood, it could be a ruptured hemorrhoid. Any of these situations, there's not much first aid that you can apply except to recognize it and get them the help that they need very quickly. Just mentioned that before. Okay, so signs and symptoms of hemorrhagic shock. We'll talk about hemorrhagic shock in a moment. So as far as this internal bleeding goes, remember, control external bleeding first. Now that doesn't mean, sticking a bunch of gauze down somebody's throat if they're vomiting blood. External bleeding that you can see. External bleeding and internal bleeding if it's a really bad trauma. Call 911 immediately and treat for shock. So speaking of which, and here's some other signs and symptoms of internal bleeding. Look at the mechanism. MOI stands for mechanism of injury. Look for bruising over the abdomen or the chest, painful, swollen, deformed extremities. Most isolated extremity injuries, single long bone fractures won't result in internal bleeding, with the exception of maybe your upper thigh bone, femur. If a broken femur can cause as much of a liter, if not more, of blood loss in that container, and that can lead the person to go into shock. Speaking of which, we're going to talk about shock right now. You've probably all heard the term shock. Most people use shock in different contexts. You may use the term referring to an electrical shock, which we'll talk about at another time. Some people refer to mental trauma as shock. But what shock is in the terms of trauma and emergency medicine is the lack of something called perfusion to all of the cells of the body. Most specifically, or most importantly, I should say, to the brain. So let's look a little bit about this term perfusion, because this is a very important term to become familiar with. Perfusion is the adequate delivery of oxygen and nutrients to each and every cell of the body. Know that. Just as important as that is the adequate removal of carbon dioxide and waste from each and every cell of the body. And as I said, the most important cells are the ones of the brain and nervous system, then the pulmonary and cardiovascular system, and then level of importance goes down the line. So what facilitates perfusion? Well, what facilitates perfusion is an intact cardiovascular system, which allows arterial blood to travel through the blood vessel with oxygen saturated and deliver those molecules of oxygen to the cells, and in the meantime pick up molecules of carbon dioxide and bring them out to the lungs for elimination. So what allows for perfusion to occur is an intact cardiovascular or circulatory system. And one of the ways we measure the way that circulatory system is working is by evaluating this person's blood pressure. Now, taking blood pressure is beyond what we're going to teach in first aid, but I'd like you to at least kind of understand how blood pressure works. Because you've all had your blood pressure taken at the doctor's office. Maybe you want to wonder what it is they're exactly looking for. So blood pressure is simply the amount of pressure that's directed on the walls of the artery as the heart is contracting and relaxing. And it's important to have a certain level of blood pressure to allow for that perfusion. So when you've gotten your when you've gotten your blood pressure taken at the doctor's office and they tell you it's whatever, 120/80, what does that really mean? Well, the top number, the 120, is called the systolic blood pressure. And that's the pressure on the wall of the arteries as the heart is actually contracting. Important to know. The bottom number, the 80, is the diastolic blood pressure. And that's the pressure that's exerted on the artery as the heart is relaxing or going into what's called diastole. If you ever wondered what they're actually looking for when they blow up that blood pressure cuff and they look at the monitor, what they do is when they blow up that blood pressure cuff, they're actually shutting off or closing down the artery. Then the doctor or the paramedic or the PA puts their stethoscope over an area that's very close to that artery. And they slowly release the pressure. So they may inflate it to something like 160. They'll release the pressure and they'll watch the gauge go down. Not hear anything. Then at about, 120, they might start hearing in the stethoscope thud, thud, thud. And what they're hearing is that turbulent flow against partial resistance of that slightly open artery. And that's considered the systolic blood pressure. By the way, I'm not testing you on how to take a blood pressure or what any of this means. I just thought you might be interested in knowing what this is all about. So at 120, and I'm just using that as an arbitrary number, they start hearing the lub-dub, lub-dub. They still release the pressure, thud, 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 thud. Then when they stop hearing that noise, when the artery is all the way open, let's say at about 70 or 80, that measures the diastolic blood pressure. So 120/80. And then there's in emergency medicine and trauma and critical care medicine, there's a formula that averages both those numbers to give what's called a mean arterial pressure, a little beyond what we need to know here. I just want you to know that it's important to have an adequate blood pressure to facilitate perfusion. Because if you don't have perfusion, you get cellular death, and then you get death. If you don't have an adequate blood pressure, you cannot have perfusion. For example, if I have a 6-story building, and I'm a landlord, and I want to deliver hot water to my tenants on the 6th floor, I have to have an adequate supply of water. I have to have pipes that aren't leaky, and I have to have some type of pumping mechanism to get the water up against gravity from the ground to the floor. So what do I need to have an adequate blood pressure that's going to do the job? So first of all, I have to have an adequate volume of blood. So in the textbook, typical, prototypical patient, generally your average size adult male would have about 6 liters of blood. Obviously, that's a generalization. Many people are different. So you have to have a good blood volume. You have to have what's called good cardiac output. You have to have a heart that's able to do the job. It's got to be able to put out blood, a certain amount of blood, within a certain amount of time, kind of like a factory worker. Then you have to have blood vessels that are in shape, that aren't too tight and aren't too open. They have to have what's called tone. For example, if I have a garden hose and I want to water my lawn and I don't have a spout at the end of that garden hose, I just have some water trickling out of that hose. What do I do to increase the pressure of that water coming out of the hose? I either squeeze the hose or I put my finger a little bit over the opening. What I'm doing is I'm increasing the resistance, and that allows the water to come out at a higher pressure. If I take my thumb off the end of the hose, I'm decreasing resistance, and that water comes out a lot slower. Now, if I completely close down that hose, if I squeeze it to the point where nothing's coming out, well, nothing's going to go out either way. So the blood vessels in your body are always a little bit contracted. They're never completely open. I shouldn't always say never, but most of the times they're never completely open. Your nervous system and your endocrine system work in conjunction to always keep those blood vessels a little bit closed. Let's go back to what cardiac output is, because that's a very important component of blood pressure. Cardiac output, how much work the heart does, is based on two things: heart rate, how fast your heart is beating, and something called stroke volume. Stroke volume is the amount of blood that your heart pumps out with each contraction per minute. So most healthy adults have a heart rate of about 60 to 100, a little give or take. A heart rate that's too slow is not going to get the job done. A heart rate that's too fast is not going to get the job done. So let's look at this formula. I'm not going to hold you to the numbers. So let's say your heart is beating 60 times a minute. And each beat you put out 100 milliliters of blood. So 60 times 100 would be 6,000 milliliters. Did I get the math right? Yeah, I think I did. So 6,000 milliliters or 6 liters. So your cardiac output would be 6 liters of blood per minute. Now, we can balance that equation. Some people have good, very healthy resting heart rates at about 50 or 48. And they can still maintain that cardiac output because their hearts beat so strong, they can increase their stroke volume with each heartbeat. So the equation balances. Let's talk a little bit about stroke volume. Stroke volume is the amount of blood that's pumped out with each contraction. And that's a component of a couple of things. Most importantly, the strength of the heart. Okay? A good, strong heartbeat is important to maintain stroke volume. Preload has to deal with how much blood is coming back into the heart. If nothing comes in, nothing's going to go out. Afterload refers to the resistance that the heart is encountering. So let's just kind of sum this all up a little bit. In order to have a good blood pressure, you have to have blood volume, cardiac output, resistance. You have to have blood coming into the heart. You have to have a heart that's contracting strong. And you have to have not too much resistance or too little resistance. Cardiac output equals heart rate times stroke volume. Blood pressure equals cardiac output, resistance, and blood volume. You're going to see how that all ties in. The body is so good at checks and balances. So if one of these mechanisms fail, other mechanisms can kick in to try to compensate and try to keep the pressure maintained. So when we talk about shock, the body's ability to, or the body's loss of ability to perfuse, one of the things the body does is try to compensate if one of these mechanisms starts becoming impaired. So shock can be classified as early or compensated, late or decompensated, or unfortunately what we call irreversible. That even if all the factors are corrected for, the damage has been so done, the person's generally going to die. So earlier compensated shock occurs when something happens, maybe we're losing blood, or maybe the heart's not beating strong enough, or maybe those blood vessels are opening up too much. But the body is working to still try to balance that equation and maintain that blood pressure. So if we are losing blood, if not enough blood is coming into the heart for whatever reason, the heart can compensate by beating stronger and beating faster to maintain that cardiac output. If that cardiac output's maintained and that resistance is maintained, blood pressure is going to maintain. If something is happening where the heart rate is too slow, maybe the heart's sick for whatever reason, well, the body may compensate by increasing the amount of blood that's delivered to the heart to maintain that blood pressure. The blood vessels may constrict a little bit more to increase resistance to maintain that blood pressure. This is one of the reasons why you start seeing the signs and symptoms of shock. And you usually start seeing the signs and symptoms when one of these mechanisms fail. So let's talk about some of the forms of shock to put this into perspective. Well, probably the most common form of shock EMTs and first aid providers will run into is something called hypovolemic shock. Hypo, the prefix pertains to decreased or less. Volemic, volume. So decreased volume. Now, what you see here is a picture of somebody in what's called hemorrhagic shock, loss of blood. And although that occurs a lot, hypovolemic shock can occur through either blood loss or any other kind of fluid loss. So if somebody is vomiting or has excessive diarrhea, they're losing heavy amounts of fluid, which makes up your blood volume, which can also reduce volume of blood or volume returning to the heart. If they're new onset diabetic and they're peeing and urinating like crazy, losing all that fluid, more fluid than they're taking in, they can go into hypovolemic shock. It just basically has to do with loss of volume, loss of fluid, loss of blood. It can happen through burn injuries, which we'll talk about next week. I know this is a pretty grotesque picture here, but I think it makes the point. So when blood or fluid is lost, the body is going to try to compensate by heart beating faster to increase the output, by the blood vessels themselves, mostly the arteries, clamping down, decreasing diameter to increase resistance, maintain cardiac output, and some other factors will occur as well. So what would be the signs and symptoms of hypovolemic shock? Remember, external bleeding can lead to hypovolemic shock, internal bleeding can lead to hypovolemic shock, or other metabolic situations like severe diarrhea or excessive urination can all lead to hypovolemic shock. Well, what's one of the first things we'd see? Well, we'd see some kind of mental status changes. Now, in the early states of shock, that may lead to little anxiousness, a little irritability, maybe a little confusion. In the later stages of shock, you're going to see lethargy, maybe even loss of consciousness. In the early stages, a person may complain of excessive thirst. Okay? Because what's the body trying to do? It's trying to signal that we need more fluid. The pulse rate, the heartbeat, is going to increase as a means of trying to increase cardiac output. The skin is going to be pale, cool, moist. Why does that happen? Well, because the body, again, likes to try to compensate. The body's very smart at what it does. We know that the most important organ to perfuse at all times is the brain. So the body will start sacrificing organs in order of least importance to more importance, to save the brain. So if the body is sensing blood loss, in order to save the brain, it's going to redirect blood flow from areas of least importance. Not that any structure is not important, but it's a priority order. So one of the first things the body's going to do is redirect blood flow from the skin to the more vital organs. So it's going to close down circulation from the skin, because the skin can go a long time, or a relatively long time, with very little oxygen. The brain cannot. So when blood flows away from the skin's going to be pale. That warm blood being diverted away from the skin is going to cause the skin to become cool to the touch. Now, what's causing this to happen? Remember we talked about the sympathetic nervous system? The sympathetic nervous system is what responds when your body is in danger. So the sympathetic nervous system causes the blood vessels to constrict in the skin. It's going to activate the sweat glands, probably as a mechanism for releasing heat. So the person's going to be cool, they're going to be pale, but they're also going to be very sweaty too. That's a very early sign of shock, early shock. Nauseous and vomiting. Well, why do you think that's happening? Well, think about it. When your body is in the middle of a crisis, it's not so important to digest a steak. It's important to not be a steak. So the digestive system is not an immediately important functioning system. So the body is going to try to redirect blood flow and activity from the digestive system and kind of shut that down to spare the heart and the brain. So whatever's in the stomach and the digestive system is just going to sit there. It's not going to move very well. So a person may start feeling nauseous, start feeling queasy, may even start vomiting. And then other things are going to happen as well. Urine output is going to decrease. You're not going to really measure that. They're going to lose pulses. We're not going to really measure that. So just kind of think about these more common signs and symptoms of shock. Mental status changes, restlessness, excessive thirst, cool, pale, diaphoretic or sweaty skin, rapid breathing to try to get more oxygen into what little blood and cardiac output we have, nausea and vomiting. These are really the classic signs and symptoms. Okay, so that's for hypovolemic shock. But there are other reasons why somebody can go into shock as well. We have another form of shock called cardiogenic shock. Cardiogenic shock. Most commonly, this occurs from a severe heart attack. The heart cannot pump enough blood to meet the metabolic demands of the body. Now, we talked about how a heart attack generally occurs, right? The heart receives all of its oxygenated blood through these arteries called the coronary arteries. If one of these arteries becomes blocked up and enough of this heart breaks down and starts dying, well, the heart's going to lose muscle mass. It's going to lose its ability to effectively pump. So if the heart does not pump strong, you're losing contractility or force of contraction. If you lose force of contraction, you lose stroke volume. If you lose stroke volume, you lose cardiac output. If you lose cardiac output, you lose blood pressure. And if you lose blood pressure, you start losing perfusion. So it's very important for that heart to maintain, to be able to pump out a certain amount of blood with each contraction. Let's say just a random number, 100 milliliters. If that heart is so damaged that it's only pumping out 40 or 50 milliliters, that may not be enough to get the job done. And so again, you're going to see those signs and symptoms of shock that we just talked about may also be coupled with chest pain if it's associated with a heart attack. They may have extreme difficulty breathing as well, because if the heart's not pumping effectively, it's not pumping out all the blood that's coming from the lungs. So the lungs can become very congested and leaky, and a person can develop fluid in their lungs called pulmonary edema. This is not a good situation. There's a very high mortality rate with cardiogenic shock. That person needs to be transported to a cardiac catheterization center ASAP. Sometimes if they can fix the underlying cause, they can save the person. Sometimes it's a matter of them needing an immediate heart transplant. But once they're in the situation with a cardiogenic shock, there's about a good 80% mortality rate that occurs with this. So it's a very severe situation. Next, more common cause of shock, maybe some of you have seen it or talked about it, is something called anaphylactic shock. Anaphylactic shock. What does anaphylaxis mean? Anaphylactic shock is shock that occurs due to a severe allergic reaction to something. Severe allergic. I mean, we're not just talking about little rash and hives and itching. We're talking about something that causes the cardiovascular system to collapse. Because what happens is when the body can sometimes be a little too good at what it does. So if something enters the body that it doesn't recognize and it doesn't should be there, the body is going to do what it can to get it out and keep it out. All right. But if the body overdoes it, the body gets it out by opening up the blood vessels, like the blood vessels become leaky, so losing fluid. It also keeps it out by shutting down the airway. So there's many different things that a person can have an anaphylactic reaction to. Insect bites, medications like penicillin, peanuts, just to name a few. Most of the time, it's not the first exposure to this. It's usually subsequent exposures because the body needs to sensitize or recognize what's going on or what it's allergic to. So you're going to see some of those other signs and symptoms of shock we talked about. Pale, sweaty skin, the rapid heart rate, rapid breathing, mental status changes. But you also might see signs of typical allergic reaction too. I don't know if you remember this movie back from a few years ago with Will Smith called Hitch. Facial swelling, hives, rash, especially around the lips and the tongue. That really is serious because that means the airway is shutting down. What's the definitive treatment for anaphylactic shock? Well, among other things, very important is the use of what's called an epi or epinephrine autoinjector. People who have had these type of reactions in the past are often prescribed these autoinjector medications, which delivers something called epinephrine into the system. You may know what epinephrine is, and another more common name for it is adrenaline. So when somebody's going into shock, what's happening? Their blood pressure is dropping, their blood vessels are opening up, their airways are constricting. What does adrenaline do? It just does just the opposite of that. Epinephrine/adrenaline will increase your heart rate. It will increase the force of contraction. It will cause blood vessels to constrict, elevating the blood pressure. It will open up the bronchial passages, allowing more air to get into the airway. It augments the sympathetic nervous system. And this is a very, very important intervention. What can you do for this person? Well, it won't do this person any good if they don't have access to it. So if they have it on them, help them get it, help them administer it. There's a video on your Blackboard on how to help a person administer it. Some first aid kits actually have EpiPens in them for the first time onset. Some person may not have it on them. EMS, they carry them on the ambulances. And really, one of the most, probably the leading cause of death due to anaphylaxis or anaphylactic shock is lack of access to early epinephrine. So really, if the sooner they get it, the better their chances of survival is. So these are very simple to use. It's not like a doctor taking up a needle and a syringe, drawing up medication and measuring it out and applying it. It's done automatically. If you can see right here, you take the medication, make sure it's appropriate, make sure it's epinephrine auto-injector. There's a couple of different brand names to it. Pull off the safety cap. You're holding it pretty much like a dagger, and you're going to press it up against the person's outer thigh. And you want to apply a little bit of pressure. It's pressure loaded, so basically it's spring loaded. So when a certain amount of pressure is detected, it spring loads the needle right into the muscle and delivers the medication. So you want to do it basically hard enough, and you want to hold it there. You don't want to just, start stabbing them over and over and over again like a horror movie. Jab it into the thigh and hold it for about a good 10 seconds. It's going to take a good 10 seconds for all that medication to get in there. And then you want to encourage the individual, if you don't want to do it yourself, to rub the area, to massage the area, to try to get the medication through the muscle and into the bloodstream. And don't forget to call 911, all right? Even if the symptoms tend to resolve, the medication doesn't last very long, 10, 20 minutes. A lot of times they'll need a second dose. A person having this reaction, they're usually monitored in the emergency room for a good 6 to 8 hours. And they're pumped with other drugs as well, which is beyond what we're talking about. And again, please look at the videos to get a better idea of what this is about. So then you have not a common form of shock, but something you still want to know about, and to get a better understanding of what leads to shock is something called neurogenic shock. Neurogenic, neurologic, nervous system. So what happens with neurogenic shock? Well, remember, one of the things that leads to an adequate blood pressure is cardiac output, but also the tone or the resistance of your blood vessels. We said that a blood vessel that is completely clamped down and shut down won't deliver any blood, but a blood vessel that's too wide open won't have enough pressure to deliver blood as well. So your nervous system is constantly readjusting the size or the diameter or the caliper of the opening of your blood vessels depending on specific need of your body. So if you can see in this picture here would be a normal cross-section of an artery at any point in time. Here's an artery that's constricting a little bit, and here's an artery that's wide open, wide open. Now, if I were to cut off the signal to that artery, it would lose its normal tone and it would just spring open to its widest diameter. What do we talk about that? That's like taking my thumb off the tip of the hose, dropping blood pressure. So there are certain times when severe injury to the spinal cord will shut off that signal to the surrounding blood vessels, causing them to all open up. If all those blood vessels open up, then what's going to happen? Peripheral vascular resistance is going to drop, blood pressure is going to drop, perfusion is going to be dropped. And this is all due to injury to the spinal cord. Another interesting thing, not interesting if you're the victim, of course, is that you may not see some of the other signs of shock as well. Remember, what causes the heart rate to speed up? The sympathetic nervous system. The nerves that facilitate the sympathetic nervous system usually come off the thoracic and the lumbar area of the spine. If this is cut off, those nerves are not going to be able to signal to heart to speed up. Those sympathetic nerves are what also activate sweat glands. So that injury, anywhere from that injury down, person's skin is going to be very dry. From the injury up, you might notice they're very sweaty. So you might see a clear delineation of sweaty skin versus dry skin, depending on the level of the injury. Not much to do for in the field except regular treatment for shock and recognize it. And this is really more academic than anything else. Like I said, the most common form of shock you're going to run into is probably hypovolemic. And then the second most common would be psychogenic. And then there's a situation called psychogenic shock, psychogenic, mental shock, simple fainting, usually due to some stress or or some mental issue that causes severe fright, overwhelms the nervous system. Either the heart rate slows down too quickly, or the blood vessels, more often, the vessels open up. So say somebody receives some really bad news that they weren't ready for. You look at your grade and it wasn't what you're expecting. The brain becomes hypoperfused, loss of consciousness or semi-loss of consciousness occurs, usually because the blood vessels just open up real quickly. It's usually self-resolving. Once the person is down on the floor, blood returns to the brain. The vasodilation or the bradycardia usually, and it's really just a matter of watching the person, making sure they didn't sustain any injuries from the fall, and treating any injuries from the fall. This is maybe the one situation where you might not necessarily have to call 911. All the other situations, definitely. So what do we do to treat for shock, regardless of its cause? Well, the first thing to do is to stop any obvious bleeding, obvious external bleeding to the best of your ability, with whatever means you have. Have the victim lie down. Remember the airway, breathing, circulation. Remember, having the gravity tends to work against the cardiovascular system. So if their blood pressure is failing and they're in a sitting up position, it's going to be more difficult for blood to get to the brain, which is the most vital organ. Have them lie down for two reasons. It helps facilitate blood to the brain. It also will help prevent them from collapsing and sustaining further injury. Now, what you see in this picture here is the Indian. I don't know why he's got a detective cap on, but they're elevating the legs 10 to 12 inches. That's really kind of an outdated and unproven means of treating shock. Depending on the form of shock, if it's hypovolemic shock, it probably won't hurt, may help, although it's never really been proven to do much of anything. If you're suspecting cardiogenic shock or anaphylactic shock, it actually may make them worse, may make it harder for them to breathe. So in general, it's probably better just to have them lie flat on their back in a straight position, or what we medically call supine. If you know it's true hypovolemic shock, you're probably going to see people elevate the legs because that's what's been done years and years and years, and it probably won't hurt, but it's probably better just to keep them flat on the ground. So obviously call 911. That's a given. Even if you think it's a transient thing, even if you're not sure what happened, leave it to the professionals. You've definitely done a good job up until now. One thing that's very important that you can do, though, is keep them covered. Try to keep that body temperature up. An interesting thing that when the body becomes cold, and that happens in a state of shock, whatever red blood cells are floating around have a more difficult time giving up the oxygen to the cells. It's just a physiologic process. By elevating the temperature a little bit, you're making it easier for the blood cells to give up oxygen, which the brain actually needs. There's no point in having oxygen in red blood cells if that red blood cell can't give it up to the tissues that need it. And keeping the body temperature up will help facilitate that. Even though this individual may complain of thirst, do not give anything by mouth. Do not give fluids to try to rehydrate them. For one thing, they may go unresponsive and vomit, in which case there's a risk of what's called aspiration, breathing in the contents of their stomach, which will lead to a very bad outcome. There's also a possibility they may need to go into surgery. And if they need to go into surgery, they need to go under anesthesia. And most anesthesiologists and surgeons don't want to operate on somebody that has anything in their stomach, at least anything recently. And last but not least, monitor. Keep an eye on them, reassess. If their condition changes while EMS is on the way, call back and give them an update on the condition. They may have to up their response a little bit. So hopefully you guys will never have to deal with this situation, but if you do, hopefully you'll be somewhat prepared. And just remember that these could be scary situations if somebody's going through it. But like I said at the beginning of class, even the little bit of first aid that you give is always better than nothing at all. If it's not you, then who else? So if you have any questions about the material that we've covered, please, 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 I encourage you to post your questions up on the discussion board. And please, 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 make sure you view all those videos and read up on the study notes that are in your Blackboard. Okay, I will talk to you guys and see you guys soon. Bye-bye. You do. And you go forever, never, never.